Hereditary angioedema. Hereditary angioedema is a rare autosomal dominant condition characterized by recurrent severe non-pruritic and non-pissing edema. It is mediated by excess bradykinin due to deficiency or dysfunction of C1 esterase inhibitor, C1-INH. Unlike allergic angioedema, hereditary angioedema is not histamine mediated, meaning it does not respond to antihistamines, corticosteroids, or adrenaline. There are three types of hereditary angioedema. Type 1. Low levels of C1-INH. Type 2. Normal or elevated C1-INH levels but reduced function. And Type 3. This is rare, often in women, associated with mutations in FX2, PLG, ANGPT1, or unknown causes. Peak incidence. Manifests in childhood or adolescence, though mild cases may present later in early adulthood. Males and females are equally affected genetically, but females often experience more frequent and severe attacks due to the influence of estrogen. Symptoms are often worsened by pregnancy, menstruation, and estrogen-containing contraceptives. Symptoms: recurrent localized swelling, skin, extremities, face, genitals, airways, tongue, pharynx, larynx, which can cause dyspnea and sometimes stridor, which is life-threatening, gastrointestinal tract. This can cause severe abdominal pain, nausea, vomiting, diarrhea, and ascites, which can mimic appendicitis or bowel obstruction. Characteristic features: non-pruritic, non-urticarial swelling, gradual onset over hours, lasting 2 to 5 days before spontaneous resolution, not responsive to antihistamines, corticosteroids, or adrenaline. Triggers include minor trauma, for example dental work and surgery, infections, stress, hormonal changes, and ACE inhibitors. Diagnosis: clinical suspicion in patients with recurrent non-pruritic angioedema, family history, and no response to antihistamines or steroids. Complement studies: low C4, both during and between attacks, low or dysfunctional C1-INH, this is type specific. Genetic testing: this identifies mutations in SERPING1 C1-INH gene or in type 3 genes such as FX2 or PLG. Complications: laryngeal edema, which can cause life-threatening airway obstruction, severe abdominal attacks, which can cause unnecessary surgeries due to misdiagnosis, and delayed diagnosis, average delay of 8 to 10 years, which increases morbidity. Management: acute treatment: intravenous C1-INH concentrate, plasma-derived or recombinant, for example Berinert or Ruconest. Subcutaneous icatibant, Firazyr. This is a bradykinin B2 receptor antagonist. Fresh frozen plasma, FFP, if C1-INH is not available. Prophylaxis: long-term, attenuated androgens, for example danazol or C1-INH replacement. Short-term, for example before surgery or dental procedures, C1-INH or tranexamic acid. Avoid triggers such as estrogen therapy or ACE inhibitors. Prognosis: with effective treatment and avoidance of triggers, patients can live normal lives. Prognosis depends on early recognition, patient education, and timely access to therapy during attacks. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today